20.
Oh, wait, we gotta wait.
I'm sorry. Okay. Ready? We ready? All right. Good evening. Today is Tuesday, July 17th, 2018. It is 6:30. I'd like to call the order of the meeting of the Central Health Board of Managers Budget and Finance Committee. If there's no objection, the agenda items will be taken in the following order: 2, 3, 4, 8, 9, 5, 6, 1, and 10. And item 7 will not be discussed today, and it is discuss and take appropriate action on Central Health owned property, including the downtown campus and adjacent properties. So we will not take that one into today. We don't have citizens, do we, Mike? No citizens, okay.
Could you repeat those order again? I'm sorry.
Sure, no problem. 2, 3, 4, 8, 9, 5, 6, 1, and 10. And then scratch off 7.
Thank you.
All right, agenda item number 2, discuss and take appropriate action on to estimate a vendor, to establish a vendor pool for geotechnical engineering services. Mr. Lamp. Thank you, Stephen.
Good evening.
Good evening.
Apologies for the casual attire. I wasn't focused on this evening.
Summer.
There's a memorandum in the board package, so I won't duplicate all of that information, but this is the last of a building design professional services pool to support a potential expansion of different locations and new buildings, include something potentially on the downtown campus. Geotechnical engineers literally design the foundation systems for buildings. Soils in this area are very expansive with the clays. They react with water, so they can literally cave in, well, make parking lots heave, and they can cave in building walls. So geotechnical engineers become part of the design team to make sure that we have an adequate design for a long-lasting facility. We did complete a competitive RFP process, request for proposals. We had 6 firms respond, and the evaluation committee selected 3 firms. These are all 2 are national firms. 1 is an international firm. We were hoping for a greater participation by local and regional firms, but we do have the participation for hub participation, excuse me. And typically geotechnical engineering firms, they are the professionals to perform their analyses. They need physical information on the soils from the different building sites. So they will contract with boring firms, sampling companies and things like that. Those are frequently hub organizations. So that's where we would expect to obtain some additional hub participation. And with that, I will end, or I can add additional detail. But
Board, any questions for Mr. Lamp?
Just one quick one. You mentioned about the hub participation. So in those ancillary areas, that will be where the activities will.
yes, none of the 3 firms selected are hubs of their own accord. So they may partner with different organizations, or they may subcontract or hire sub-consultants to pick up the hub requirements. We will enter into parent consulting agreements, and then on a task order basis, we'll say, okay, here's a building location, here's the size and the parameters that we need. And at that point in time, they will have to respond back with a specific team and fee proposal.
Okay. All right.
Vice Chair, any questions?
None.
Madam Daniel? Vice Chair, Chair Daniel, sorry. None? Okay. All right, do I hear a motion?
Motion?
Yeah.
I move that let's see, here we go. Yeah. I move that the committee recommend the board approve the establishment of a vendor pool for geotechnical engineering services in an amount not to exceed $100,000 to be allocated as appropriate among the selected firms, and authorize Central Health's president and CEO to negotiate and enter into agreements on terms similar to or more favorable than those presented with ECS Southwest, Fugro, and Terracon Consultants.
Is there a second? Okay. So we have a motion by Ms. Daniel and second by Dr. Akins. All in favor say aye.
Aye.
All against say no. Anyone abstaining? All right, motion passes. All right, agenda item 3, discuss and take appropriate action to establish a vendor pool for legal services. Ms. Aquino?
Hi, everyone. So I'm actually here in Stephanie's absence, and she was the sponsor for this procurement that we did for legal services. And we issued an RFP for legal services based on feedback we've received from the board in the past, requesting that we go out for competitive procurement for legal services. And so we issued the RFP in May of this year. We had a very good turnout. We had 17 responses.
How many?
17.
Wow, that's why we do RFPs.
Yes. And that represented everything from single person firms all the way to, some of the largest firms in Texas. And the evaluation committee evaluated the proposals and have selected the 4 firms that are included in your packet: Haynes and Boone, Locke Lord, Myertons, Hood, Kivlin, Cowart, and Goetzel, and Winstead. And these firms have a variety of expertise, including a boutique firm that does solely intellectual property, which is something we may need in the past based on board action, and healthcare, real estate. And what this will allow us to do is have contracts with these firms that are in place and allow efficiencies when staff need to obtain legal counsel. And the financial impact with these firms will be included in the overall budget for legal services, which will be determined by the board through budget approval. And they have no guaranteed NTE on any of their contracts. They're to be as needed.
Thank you, Nicole. Chair Daniel, any questions? Dr. Higgins, Vice Chair? Mr. Jones?
Is there a history with any of these firms?
So actually, I believe that the CCC may use Locke Lord, but Central Health has not used.
Seeing no other questions, do I hear a motion, please?
I move that the committee recommend the board approve the establishment of a vendor pool for legal services and authorize Central Health's president and CEO to negotiate and enter into agreements on terms similar to or more favorable than those presented with Haynes and Boone, Locke Lord, Myertons, Hood, Kivlin, Cowart, and Goetzel, and Winstead.
Very good.
Do I hear a second?
Yes, that was, thank you. I deserved it, thank you.
Okay, we have a motion by Chair Daniels and seconded by Dr. Akins. All in favor say aye.
Aye.
All against say no. No. No abstentions. Motion passes. Thank you. That was quick. Thank you, Nicole.
Thank you.
All right. Agenda item 4, discuss and take appropriate action on agreement between Community Care Collaborative and Covenant Management Systems, LLP, doing business as MediView for claims processing and third-party administration services. Morgan. Good morning, Dr. Hernandez, and
Evening. We will jump right in. Tonight we're here with a request for approval by the Central Health Board of Managers for an administrative services agreement with MediView, which is a DBA of Covenant Management System, to provide third-party administrative services, claims processing services for the healthcare that we pay for. Just as a few high notes, you also have more detail in a memo in your backup packet. About 12 months ago, the CCC entered into an agreement with Seton Health Plan for the same administrative services through an affiliated organization of Seton Health Plan called Automated Benefit Services. Unfortunately, ongoing configuration concerns and system limitations have prevented us from completing that go-live, and today we're here to propose a transition to a new third-party administrator. Right now, in order to really minimize the impact of the configuration limitations and our inability to go to a complete configuration with ABS, we've been processing a large volume of our healthcare claims in-house with our staff. So today, about 75% of the claim volume that we see on a monthly basis is being processed manually or through alternative electronic submission requirements. Back in December, we started working with the leadership at ABS and at Seton Health Plan or Seton Insurance Services to try to remedy our problems. After about 3 months of working on that, we decided that we needed to start looking into alternative solutions. So now we're here today with this recommendation. Our recommendation is with MetaView. As I mentioned, they're a DBA of Covenant. Covenant Management Systems is an affiliate of Seton Healthcare Family, which requires us to bring this item to the Central Health Board. It's also a large dollar amount contract that triggers a member reserve power for Central Health. MetaView has a demonstrated ability to handle our healthcare claims. They've had 2 prior engagements with the CCC and Central Health to process MAP claims. We're confident in their ability to fully configure the system in the way that we need it to pay our providers for services. Like we did before, we're seeking a long-term arrangement. As you all know, we've had to do this transition a few times over the past few years. And our goal is to get to a structure that's a multi-year agreement that is financially sustainable and efficient way for us to pay for the healthcare services. So the details of our request, this is a little more lengthy than most of the things we bring you, but we're asking you to approve the CCC to enter into a contract with Covenant Management Systems, DBA MetaView, for these healthcare claim processing services. The way this contract is structured is as a multiple year renewal options for us. We've been able to work with the folks over at MetaView to get fixed pricing that is equal in amount. This $1.5 million is an equal amount to what's in our budget today, so we've gotten them to agree to match our current pricing mechanism. You see an initial term of $500,000 that allows us to get to work on configuration immediately, and then because MetaView's had our business before, they already have a lot of the things configured that we need them to configure. So we're looking at a partial go live as early as September 1st. And then we have an agreed upon price inflator for the renewal terms past the second full year renewal. With that, I'm happy to answer any questions, or Jeff, Mark, anything you'd like to add?
Well, these last two things I took backwards, so I'm gonna listen for a motion first. Can I get a motion from anyone?
Yeah,
You want me to read it?
read it from here.
You want me to read it? I don't have one. Can I read it from here? Yeah, okay, yeah, sorry. So, I need to read the motion?
Whomever, it just needs to be read from there because there's a typo in the other section.
So go ahead.
Okay. can you
Which
read?
one is it?
That one.
I move that the committee recommend the board approve and direct the Central Health appointees to the Community Care Collaborative, CCC, Board of Directors to approve an agreement between the Community Care Collaborative and Covenant Management Systems LP, DBA MetaView, for claims processing and third-party administrative services in an amount not to exceed $8,475,000.
So here's a second.
Yes.
Yeah, okay. So we have a motion on the floor by the Vice Chair Greenberg and seconded by Dr. Akins. Now we'll take some discussion. Mr. Jones?
What is the relationship with Seton and MetaView, did you say?
I believe that Seton Healthcare Family and ARC are partners in Covenant Management Systems, a limited partner.
Not MetaView.
That's correct.
Not MetaView, but the current one.
MetaView is an operating department of Covenant Management.
Okay, so,
Covenant Management Systems is a joint venture between Seton Healthcare Family and Austin Regional Clinic. They operate a TPA through MetaView. They operate as an operating division. MetaView, they also have some other care management services, nothing that we're engaging with. But Covenant essentially handles all of the administrative work for ARC as well as operates a TPA called MetaView, both for ARC as well as it is available for other companies to contract with.
Well, my question was just going to, is there a capacity, given what you've dealt with Seton? Do you feel that they have the, obviously you do, but I just want to put that on the record that you're comfortable that they have the capacity to do what you're asking them to do?
We're comfortable that Metaview can handle it.
Yes,
Yes, sir.
okay. That's it.
Chair, Roger.
I thought I heard you say that you had used Metaview previously,
Yes, ma'am.
and why did you discontinue that, and why are you commencing again with Metaview?
So twice before, Metaview has had the contract to process claims for MAP.
Right,
First time was before my tenure here. And we moved from Metaview at the time to Valence,
I
which was
remember.
contracted through Sendero.
yeah.
From there, I believe both Sendero and the CCC moved away from Valence and moved to a temporary transitional type of agreement, a one-year agreement with Metaview. And that's where the CCC, during that transitional period, issued an RFP in early 2017, and ABS was selected as the vendor out of that RFP process.
And ABS is the Seton,
ABS is so both of these are Seton affiliates.
right, so explain.
ABS is a owned entity by Ascension.
Right.
That's who's processing the claims today.
Okay,
Different company, both Seton affiliates. It's a bit confusing.
But it seems like there's a difference. ABS is actually an Ascension entity.
Automated Benefit Services, which is the affiliate company from Ascension, was a separate standalone TPA company, which Ascension purchased at some point in the past and became a solely owned subsidiary
Of
of
Ascension.
Ascension.
Right, and that is the one that is, how shall we say, not working.
Correct.
Now, Metaview is, I guess, a joint partnership between,
Historically, it's been Seton, so the local Ascension ministry, and
Austin Regional Clinic.
And that company actually kind of predates Ascension's kind of direct interaction with Seton.
So is this one a local as opposed
It's a
to
local
an Ascension?
company.
That's
Yeah,
correct.
It's local.
It's local as opposed to the current one, which is Ascension.
Yes, this is an Austin-based company as
Right.
opposed to Automated Benefit Services, I believe is out of St. Louis.
St. Louis, if it's Ascension, it should, unless it did Delaware or something.
Excuse me?
Well, I'll go after the members. I just
Okay.
wanted to get in the queue.
Okay.
Right.
Dr. Dickens?
Really quickly, I just wanted to check that the change doesn't affect the continuity of data, so will there be a disruption in being able to link things, or will this be ceiling?
We have some challenges related to data from this current year due to these difficulties.
Yeah, I knew
As
that
a
much.
result of processing things in-house, we're taking some additional steps to make sure that data is usable for us going forward.
But we're not going down a path where it's gonna get trickier.
I think it'll get better.
Better.
Just checking. Thank you.
Data is a big part of what we're doing here with the TPA. I mean, we have these mechanisms to pay our providers manually, but to your point, we don't get as usable or as timely of data as if we have an electronic TPA.
Yeah.
We, how does this translate to volume or size? So do we look at a claims volume or per life?
This is on a per claim basis, and we have a fixed per claim rate for the first 26 months. First 2-month term and then the first 2 full-year terms. We have a fixed rate, and then we have a 5% per year inflation following that.
And what's the per claim rate?
I don't know if I can
Okay.
discuss that.
I have another question.
Sure.
Um,
Go ahead.
yeah, I'm sorry. What kind of capacity or volume do they currently process? So they've got ARC,
They have ARC, they were contracted with Sendero recently.
Medicaid line for Sendero.
And Seton,
ARs. Well, I think it's mainly outpatient is what I'm guessing that this is for.
It's
But you mentioned Seton too.
For us, it's mainly outpatient. Are you asking about the volume of
I'm just trying to
our
get a,
contract?
no, for this, the capacity of this,
Review.
yeah, MetaView.
They've processed historically for full spectrum of care facilities as well as outpatient.
How
So
many?
they're local,
They are, yes.
and I'm just wondering, kind of, do they just really work with Seton affiliates, or are they,
So they also, they serve as a TPA for other third parties. It's not just a, I don't think today Seton has any of their claims or their insurance products.
They're all on ABS.
Jason?
So I apologize, I should have asked this in one of the working group meetings, but in the course of doing the diligence around this, did you all run some volume through their systems to test it, just to see how it played out?
We have not yet. That's part of this 2-month startup period. Configuring the system, doing joint validation of the fee schedules and the provider-specific setups and testing claims. That's something that we will start on immediately. Our staff and the MetaView staff have been working together on those configuration rules, but the testing would actually start after the contract's exit.
I have a question.
Vice Chair?
So, given the challenges that we've had in this area, just want to ask again, I know Manager Jones and Manager Daniel asked, but it's a local company, it's Seton and Austin Regional Clinic. What you said is right now they're not processing claims for Seton, they are for Austin Regional Clinic, they have for Sendero and for some others. And what you just stated is this $500,000 is for the 2-month initial term to do some testing. What happens if the testing is not satisfactory, because that's going to be post-execution of the contract?
We have termination provisions that are built in, both for non-performance and we have without cause.
We do, okay, good. And one other question, you said that the 1.5 for the 1-year renewal, sorry, is current budget, but I assume the $500,000 is something that's not in current budget, that's beyond current budget.
No, ma'am.
Okay.
I expect the 500,000 would be paid out. We would not exceed our budget for
Good,
this year.
okay, thank you.
Excuse me, any other questions?
No, sir. Thank you.
Board, any other questions? All right, so we have a motion on the floor. Vice Chair Greenberg, and then seconded by Dr. Akins. All in favor say aye.
Aye.
You can say no. All right, passes. Thank you.
For your time.
Thank you.
You,
All right, the next two are going to be taken together, is that correct, Holly? So agenda item 8, discuss and take appropriate action on the 1115 Medicaid waiver, delivery system reform incentive payment, DSRIP projects, community care collaborative, including healthcare delivery arrangements and other interrelated community partnerships. Agenda item 9, discuss and take appropriate action on an update regarding Sendero Health Plans, Inc., including the effect of federal legislative and regulatory actions. With that, I'd like to go into executive session. I announced that the committee is convening an executive session to discuss agenda items 8 and 9 under section 551.085 of the Texas Government Code, deliberation of governing board of certain providers of healthcare services. It is 8:47, and committee will reconvene in open session. No action will be taken on items 8 or 9. With that, item number 5, receiving a report of the June 2018 financial statements for Central Health. Lisa.
Good evening. Thank you. So I have the Central Health June financial statements through the first 9 months of the year. A few highlights from June. We did send an intergovernmental transfer of $13.8 million related to uncompensated care. We also made a $15 million member payment to the CCC. And year to date, we have net property tax revenue of $181 million received. Looking through the balance sheet, our assets at the end of June 30th, 2018 were current assets of $114.7 million and total assets of $319.5 million, which includes non-current and capital assets. Our liabilities, current liabilities, were just over $12 million, and our non-current liabilities, which includes debt service, just over $8 million for a total of liabilities of $20.6 million, which leaves our net assets at $298 million and our total liabilities and net assets at $319.5 million. This month, we did have sources of funds totaling $1.3 million, which consisted of $250,000 in property tax revenue and then other revenue and lease revenue. Our uses of funds, we had $30.2 million in healthcare delivery. We'll go into that in a little bit more detail on the next slide. And our administrative program had monthly expenses of $571,000. Our total uses of funds for the month of June were $30.7 million, and our fiscal year-to-date uses of funds were $151.2 million. Our total sources over uses for the year-to-date was $94.3 million as of June 30th. A few more highlights on expenses in healthcare delivery area. We had primary care expenses of, let me start with intergovernmental transfers. As I mentioned, we did have a $13.8 million intergovernmental transfer for uncompensated care. And then we also had healthcare delivery of $11,000 and a $15 million member payment to the CCC. Our healthcare delivery operating costs were just over $520,000 for the month, and other costs, which includes expenditures around the campus redevelopment and our ACA enrollment and subsidy, were $788,000. Our total healthcare delivery for the month was $30.2 million, and for the year as of June 30th was $144.4 million. And finally, just, shows that we had our final UC payment in IGT. Any questions?
Any questions, board? Seeing none, we'll move on to agenda item 6, receive a report of the June 2018 financial statements for the Community Care Collaborative. Ms. Owens.
Okay. Of our financial statements for the CCC, Community Care Collaborative, through June 30th. Balance sheet shows that we had total assets of $51 million. That is primarily of cash and cash equivalents. Our liabilities, AP and accrued liabilities, which includes incurred but not received for providers, of $28.3 million, deferred revenue of $2.8 million, and total liabilities of $31.8 million, which leaves net assets, which includes emergency reserves, of $20 million. Our total liabilities and net assets of $51.8 million for June 30th, 2018. Our sources and uses report, we do have year-to-date numbers reported here. Our DSRIP revenue at $56 million, member payments year-to-date from Seton at $30 million. We did receive an additional $20 million payment from Seton in the month of June, And as I mentioned on the Central Health financials, Central Health made a $15 million member payment in June as well. Our total sources of funds year to date as of June 30th were $114.8 million. Our uses year to date as of June, healthcare delivery, we are at about 62% of our budget at $63.9 million. The UT services agreement was paid in June for $35 million. And our DSRIP project costs, we talked about this when John was here with us last month, but the DSRIP program has been in a transition. We have incurred about $707,000 in expenses, but you will start to see those start to pick up with the new contracts and new programs. So our total expenses in the month, year to date, were $99,000, just under $100 million, $99.7 million. Total sources over uses at $15 million. A little more detail on the healthcare delivery. Specifically, we'll go into more detail on primary and specialty care on the next few slides. But you'll see that at three quarters of the way through the year, for many of our partners, we are tracking well at about right around 75%. And we'll talk a little bit more about primary care and specialty care on the next slides. Pharmacy is at 56% at $3.5 million, medical management at $1.8 million. And then, again, additional information on the next slides, but our total healthcare delivery year to date is $63.9 million. Our primary care contracts are listed here. Does include our 4 primary care clinic systems as well as some of our other contracts in this area. Year to date, we are at about 71% of expenses to budget, with our largest partners, community care, right on track at about $30.9 million of their budget year to date. Total primary care expenses year to date, $37.1 million. Have additional information on specialty care. Members, I wanted to make sure that you know that we did make some changes to these slides from your earlier packet. It was in the prior year-to-date actual, and that did not affect the current year-to-date actual. We just got some things reconciled on the prior year-to-date. However, year-to-date, primary care is at just about $6 million. Our budget is $13.475 million. We're at about 44%. But you'll see year over year we are spending significantly more than last year in primary care. Some of the year over year comparisons may have to do with how we categorize things last year versus this year. We've talked a lot about how as the community care grows and expands and changes programs, that has demonstrated just a little mapping necessary as we get more mature. But for the most part, our specialty care contracts are that have been in effect much longer, such as orthotics, ophthalmology, and some of these long-standing partners are performing really well and tracking towards their goals. And then some of our other programs, I think John pointed out last month, we just haven't even started working with the new partners yet. So some of this is due to budgeting for things that have not even been contracted for yet. So just hitting a few highlights, our specialty care with community care is at $1.8 million out of their $2 million budget. I would point out that ophthalmology, the line item is over budget, but we have contracted with more providers in order to deliver more services. So we are not over any contractual amounts. It's more just the budgeted line item. And I think I mentioned several projects have not started any programs yet or services such as the palliative care, physical medicine, remote patient monitoring, and rheumatology. And finally, as I was mentioning, just making sure that some of these programs were new, breaking out eligibility and enrollment as their own. That you won't see a prior year to date. That was in a different area last year. But you will see that we are well under budget in most of these areas, with eligibility enrollment at about half of their approved budget. Our QAP, which is Quality Assessment and Performance, as well as our PMO. Total healthcare delivery operations in the 6 departments is budgeted at $12.9 million, and we are about 51% of the way spent there at $6.6 million year to date. I will answer any.
Board, any questions? Ken?
I don't have a question, just a comment. This is excellent information, and I would venture that probably not 1% of the general taxpaying public understands not so much the numbers, but what we do and how we do it. I think to the degree that we could look at how do we, in a general format, help this individual understand that we take these dollars, we work these efforts in this community would go a long ways to help mobilize and to get support for the efforts we're doing. So I would encourage us maybe to look at how we can synergize this in such a way so that we can convey it to the general public. Not John Q necessarily, but leaders in the community.
The annual report?
Annual report is fine, but I don't think we should do it at the end of the year. I think maybe throughout the year.
Oh, a periodic.
We could talk. For instance, we were on the radio show the other day, and we were talking specifically about what Central Health does. And we went into some of that. We don't do it. We contract to get it done. We're responsible for it. And I think the fact that we contract with a lot of these providers, I think would go a long way for people to understand that those are the arms and legs of what we do. And so I just encourage us to consider some kind of proactive way to help get this message out to the general public.
Before this man speaks, I'm going to speak because I know this board has heard me say this before. That's why I fell in love with this guy. Because he came to us at his interview and said he was going to have end-of-driveway discussion. And I mean, he's really a great communicator. And we've relied so much on Mike to do that for us. So now I'm going to let Mike speak.
Thank you. And we agree with you on that. And I think set aside all the digital communications for a moment. And if you look at our community conversations that we staged, starting with the strategic plan discussions after the Germain Solutions report came out, that's what a lot of this was about, was talking about, we execute through partnerships. And it coincides with what you and Larry talked about on the radio whenever we were at KAZI the first time too, talking about everything we do is through partnerships. The dollar amounts, we have some upcoming community conversations where we're going to be talking about the budget. And then, of course, we have the staging, not only in these meetings, which are televised, as well as webcast, but then sitting in front of the county commissioners' courts. And we're going to continue with this narrative arc of we leverage these partnerships to be able to do just this right there. And if nothing else, showing the specialty care slide.
Right,
impressive.
right.
Because it shows that we've, not quite doubled, but almost doubled, what the spend is, but we have very extensive contracts. So that's going to continue. In fact, I would issue the challenge to everybody that's out in the community, not just staff, working these various community events, through our health champions and social media and all this, but anytime any of a board member goes out, that's why we have on our library these information sheets to be able to empower your information bank so that when you are out in the community, you can help talk this up. So we agree with you wholeheartedly on that.
Can I weigh in on that for 1 second?
Of course.
So I agree completely. One of the things that we did in the last budget cycle was add funds in for community communications. And it was related to just this thing that you're talking about. In fact, I think we struggled with, we're not really trying to do a PR campaign, but I do think there is a question about, do people in the community understand whether it's the patients we serve, the taxpayer, leaders in the community, what does Central Health do? We like to say that we contract for healthcare services, we partner, we do, and I think in explaining that, we might lose the message of what you're talking about, which is, we may not stick the shots in the people's arms ourselves, they may not be direct employees, but we do, we're, the specialty care is because of us. So I think, where I'm going with this, I think it's worthwhile to take this question to the firm that we hired to help us with that messaging. How can we not get bogged down in the details of the way we do our work? How can we make our message about the impact of Central Health quotable and memorable? We do have lots of resources for board members. We ought to be ambassadors in the community, but it's hard to be an ambassador when it's so daggum complicated. If we can boil it down, and that's what I think we wanted, I think it's Sherry Matthews, is that who we engaged?
Yes.
Yeah, so, but anyway, so, going to the firm and saying, how can we take the complexities of this system that we fund and that we partner in and boil it down to memorable and quotable impact statements that you can say, I can say, Sherry, Cynthia, Abigail, whomever.
And
Well,
I need to respond to what she said after you go.
yeah, and if I could, yes, I, as Katrina was alluding to, I went to the mat over this with the board a couple years ago to get funding in the budget for this education.
You had some support.
Absolutely. That's just what Katrina was alluding to. There were several of us, yeah. And it is the need to have what I call the clear, compelling narrative, which we did begin with that education campaign. There were focus groups, there was all kinds of research and testing of it, and I think it did do a good job of really, through the messaging and through the pictorial narrative that you saw, do that. But it has to continue.
Yeah.
It has to continue.
In terms of face-to-face community level meetings, social media presence, I mean, I got to say, we've been knocking it out of the park. So,
but it does have to continue, and this is something that Katrina has been an advocate for, and before that, another board member, and that I have been, and that Ted has also spoken about, and that is, it's not a one shot. Are we not on topic?
Getting a little far.
Getting a little far. I kind of noticed that. All right. Well, to be continued. We can add this to our next strategic planning committee meeting where we will have Ted come.
Sorry, Council.
Yep.
Any other questions? Seeing none, we'll move on to agenda item 1, approve the minutes of the following meeting of the Central Health Board of Managers Budget and Finance Committee, June 13, 2018. I'll entertain a motion.
Move approval.
Okay. Second?
second.
So I hear a motion by Vice Chair Greenberg and seconded by Board Member Katrina Daniels. All in favor say aye.
Aye.
Say no. Okay. Motion passes. All right, we're down to agenda item 10, confirm the next regular committee meeting date, time, and location. The next Central Health Board of Managers Budget and Finance Committee meeting is scheduled for Wednesday, August the 8th, 2018, at 5:30 p.m. Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702. And with that, I'll entertain a motion to adjourn.
Adjournment.
Second? Is there a second?
Second.
All right, all in favor say aye.
Aye.
Thank you, everyone.
Appreciate it.
Thank you, everyone.
I was thinking we were at that